The digestive system consists of the alimentary canal, which is your GI tract, and is for digesting food and absorbing food. Mouth, pharynx, intestinal, esophagus, stomach, small intestine, large intestine, and rectum, anus, and then out. Accessory organs, teeth, tongue, gallbladder, digestive glands such as salivary glands, liver, pancreas. And here we have a picture of the general gut. You can see your mouth and tongue, and here's your salivary glands, parotid gland, sublingual, submandibular gland, your pharynx, this is your esophagus, this is your liver, gallbladder, stomach. The pancreas is this little yellowy tissue here. And then you can't really see exactly, but coming off the stomach is the first section, the duodenum. The second section is jejunum, and the third section is ileum. The ileum feeds right into the cecum, and you have your vermiform appendix, which is what's left of the original functional cecum in the human. Then your colon, we have ascending, transverse, descending colon, sigmoid colon, and then out. Activities for digestion, ingestion, propulsion, that's eating, moving things along, mechanical and chemical digestion, absorption, and defecation. This is showing a picture of peristalsis. This is supposed to be the esophagus, and you have waves of contraction that move the food down until it gets to your stomach. Now, segmentation could happen in your gut, and you have contraction here, then here, then here, then here, and it moves food up and down and forms, pushes it back and forth where you get movement of the food for digestive purposes. Okay, regulatory mechanisms, we have both mechano and chemoreceptors in our intestinal tract. They respond to stretch. So you eat food, you stretch your stomach. Changes in osmolarity and pH. So as you have a stomach that's full of acid and then you dump a bunch of food on it, it becomes less acidic, and so that will cause the digestive process to start. Presence of substrate, food, and then the end products of digestion. And these receptors initiate activities that activate or inhibit digestive glands, and then stimulate smooth muscle that moves contents of the gut. Okay, the peritoneum is the serous membrane of the abdominal cavity. The visceral peritoneum is the outer surface of the digestive organs. Peritoneum lines the body wall. The peritoneal cavity is the potential area between the two peritoneums, and it has fluid, lubricates, and keeps the guts moving nicely. Mesentery is a double layer of peritoneum. So the peritoneal comes in the front, so this is from the anterior part, and then it comes into, winds around the back here, and like this, and your guts are attached to the back part. It's routes for blood vessels, lymphatics, and nerves. It also holds the guts in place and stores fat. Now, some organs are retroperitoneal. That means they lie outside the peritoneal cavity. And then most digestive system organs are intraperitoneal or peritoneal, and they are within the peritoneal cavity. Arteries that supply the gut and hepatic, splenic, left gastric, inferior, and mesenteric. And then our hepatic portal system drains nutrient-rich blood from the digestive organs and delivers it to the liver for processing. I had a student asking about alcoholism and portal hypertension, and I forgot to mention it in class, but portal hypertension is when you have too much pressure in the liver because of cirrhosis, and so the blood can't really flow through the liver, so you build up pressure, and rather than systemic high blood pressure, what you get is rupture of vessels involved with the gastric system, with the digestive system. Okay, main tunics or layers of the alimentary canal, that means your gut. Mucosa, innermost, submucosa, muscularis externa, and serosa. Now, the mucosa is a lining. It secretes mucus, digestive enzymes, hormones, absorbs product digestion, helps fight against disease. And within it, you have three layers: epithelium, lamina propria, and then a little thin muscularis mucosa. Epithelium is an inner part, simple columnar in place in the gut, secretes mucus secreting cells. The mucus protects the digestive organs from digesting themselves and also eases food passage. And the lamina propria is just under the epithelial tissue because, or you say under, it depends on which side you're looking. Look at the mucosa. The epithelium is the very innermost part, and then the lamina propria is right under the epithelium. We're still in the mucosal layer. It's connective tissue, and this is where your capillaries for nourishment and absorption and your lymphoid follicles are. And then the muscularis mucosa is smooth muscle that makes little local movements of mucosa. The submucosa is dense connective tissue, and this is where we have a lot of blood and lymphatic vessels, lymphoid follicles, submucosal nerve plexus. Now the muscularis externa, these are the muscles for segmentation and peristalsis. You have an inner circular and outer longitudinal areas. Also, we have a myenteric nerve plexus. Now, the my means muscle, enteric means gut. So this is gut muscle nerves. And there are sphincters in some regions. You're quite familiar with ones such as your external anal sphincter, for instance. Okay, the serosal layer, this is a very outermost layer. If you're outside of the digestive, outside of the peritoneal cavity, such as in the esophagus, it's called an adventitia. So retroperitoneal organs have an adventitia as well as a serosa. Now here we have our gut in general. This is our epithelium. This is our epithelial layer. This is layer just under it, the myenteric layer of the gut. And then we have here our submucosa. And then this is our muscularis. So we've got two layers, inner circular, outer longitudinal, and then our serosal layer. So we go from mucosa, submucosa, muscularis, and serosa. If you were going to cut into it, you'd start with serosa, and then you'd go to muscularis, submucosa, and mucosa would be the last thing you would cut if you were doing surgery. Enteric nervous system, sympathetic impulses inhibit digestion, all digestive activities. Parasympathetic stimulate digestive activities. The mouth is also called the oral or buccal cavity, bounded by lips, cheeks, palate, and tongue. The oral orifice is the anterior layer, also outer layer, lined with stratified squamous epithelium. And you can always remember, if it's something that has a lot of friction on it, it's going to be stratified squamous epithelium because it's the thickest epithelium there is. And this is a place we get friction because we eat potato chips and crunchy foods. Now here's your oral cavity. This is your uvula hanging down. All this is tongue, hyoid bone. It's really kind of hard to see much more on this picture. Here's your esophagus. Okay, lips and cheeks, orbicularis oris and buccinator muscle. Vestibule, I think I'd be better off just looking at this picture. The vestibule here is between the gums and the lips. It's in here, like where you put your red man chewing tobacco. But please don't do that. It's disgusting. Okay, other things we have, the gingiva or the gums. Hard palate up here, if you notice, it's corrugated. And then the soft palate back here, it's got a lot of muscles. This is your uvula. These are your palatine tonsils here. These are ones they take out. Somebody said, which one do they take out when they say they're taking your tonsils out? These. They also usually reach up under here into the nasopharynx and get your adenoids. Okay, this lip is a labium, so this is a superior labial frenulum here. This is the inferior labial frenulum. This is the lingual frenulum. Now, salivary glands, we have openings for the ducts, those glands. Submandibular salivary ducts open right here. Sublingual salivary glands open here. And then our biggest salivary gland, which we'll talk about in a minute, opens up under these teeth. Okay, and we talked about the hard palate, the soft palate, but the soft palate closes off the nasopharynx during swallowing. Okay, the tongue is for repositioning, mixing food, during chewing, formation of the boluses, swallowing, speech, taste. Intrinsic muscles change the shape of the tongue. Extrinsic muscles alter the tongue's position. So you stick your tongue out, that's an extrinsic muscle. The lingual frenulum attaches the tongue to the floor of the mouth. The surface, I think I did miss that other salivary glands. Let's see if I got a picture back here. Just like a real lecture, lost as could be. Okay, here we go. Nope, I can't find the picture. Okay, we probably have it eventually. Okay, the tongue has your papillae. The filiform provide friction. Whitish, give the tongue roughness. Fungiform, reddish, scattered all over the tongue. Circulate, V-shaped row in the back of the tongue. And all these three house taste receptors. Folate are on the lateral aspect of the tongue. So here are alate papillae, our fungiform and filiform are all here. These are folate papillae here. Really, they used to talk about that you tasted sweet on the tip of your tongue and bitter on the back of your tongue, but that's been disproven. Okay, here's our salivary glands. I thought they might come out here. The parotid, the submandibular, and sublingual salivary glands are extrinsic salivary glands. Intrinsic are within the mouth, little bitty glands throughout the oral mucosa. And saliva cleanses the mouth, moistens and dissolves food chemicals, helps you form a bolus where you can swallow food, and contains enzymes that help break down starch. The parotid salivary gland, this is a big one, external to the masseter muscle, and the parotid salivary duct opens in the vestibule next to the second upper molar. Now the submandibular gland is medial to the mandible, and the duct opens at the base of the lingual frenulum, and the sublingual glands are anterior to the mandibular gland under the tongue. That's why it's sublingual. And you have 10 to 12 ducts on the floor of the mouth. So here is our parotid salivary gland. And here's the duct right up here. Submandibular here, sublingual here. So you can see the ducts, the sublingual. The submandibular has ducts right here. Okay, and that's the same picture. So here's our ducts again. Submandibular, sublingual, and then the parotid here. You have the gland opening right here, which doesn't show on this picture, but it'd be right in that area. Okay, composition of saliva. Secreted by serous and mucous cells, mostly water, slightly acidic, has electrolytes in it, salivary amylase and lingual lipase, mucin, some metabolic wastes, Also, lysozyme, IgA defensins, and a compound that protects against microbes. Control of salivation, intrinsic glands in the mouth continuously keep the mouth moist, so they should be going all the time. And extrinsic only should start producing secretions when you ingest food and you stimulate chemical and mechanoreceptors in the mouth. Now, these are both stimulated by parasympathetic stimulation in cranial nerves 7 and 9. Now, you can even think about food and start salivating with these extrinsic salivary glands. Now, if you have sympathetic stimulation, like you're about to give a speech, you'll get a dry mouth because sympathetic stimulation inhibits salivation, and that's xerostomia, no saliva, your mouth's dry. Okay, teeth. We have our primary and our permanent dentitions. 20 deciduous teeth, and they've all erupted by about age 24 months. Then the roots will be absorbed as the new teeth come in. 32 permanent teeth, all except the third molars, erupt by the end of adolescence. The third molars are your wisdom teeth, and they take longer to come in. You can see the little deciduous teeth here being pushed out by the permanent teeth. Incisors are for cutting. Canines are for tearing or piercing. Premolars and molars have crowns with cusps for grinding or crushing food. Now here's your incisors, your deciduous teeth, and these are your permanent teeth. So incisors, the central, come in 6 to 8 months. Lateral, 8 to 10 months. Canines come in 16 to 20 months. And then the first molar, 10 to 15 months, and second molar by 2 years. Now, on the adult teeth, the central incisors come in at about age 7, and then 8, you get your lateral incisors. Your canines come in, it's also called the eye tooth, about 11. Also, you get your first premolars at about 11. Now, your first molar actually comes in at 6 to 7. Second premolar, 12 to 13. Second molar, 12 to 13. Wisdom teeth may take as long as 25 years to come in. You can see the difference in the shape of the different types of teeth. This is showing the actual anatomy of the tooth. The enamel is your outer coating. This is the hardest substance in the body. This is your dentin with tubules. The pulp cavity here. And then this is going to be your root canal. This is a periodontal ligament, the white stuff. This is your gingiva, and this is the bone that it's embedded into. So the crown is the top of the tooth, the neck right here, and the root right here. Dental caries are cavities. You get demineralization of enamel and dentin. It starts with dental plaque, sugar, bacteria, and debris adhering to teeth. Acid from the bacteria dissolves calcium salts. Enzymes digest the organic matter in the tooth, and to prevent cavities, daily flossing and brushing, as well as using fluoride toothpaste. Gingivitis is plaque is calcifying to form tartar, and it eventually starts to interrupt the seal between the gingiva and the teeth. And you can get anaerobic bacteria into the gums. Now, if you remove the calculus, that has to be done by your dental hygienist. This is a reversible process. Periodontitis, you've left that gingivitis alone, and you start to get attack on the periodontal ligament by both the germs and the immune system. Bone loss results, and you end up, this leads to heart attack and stroke. Now, the reason for this is because as a little piece, you have this horrible germs, you chew a little piece of this germs, it breaks off, it bleeds, you seed your bloodstream, and any little place you had in these arteries tends to, any little place you had this has inflammation, these bacteria feed in. So the way I got my kids to brush their teeth was told them if they didn't, they were going to have a heart attack and die. That's probably the best way to get them to do it until they find out about the opposite sex, and then they'll brush them voluntarily. Okay, the pharynx consists of the oropharynx, which is above the soft palate. No, I'm sorry, the nasopharynx is above the soft palate. Oropharynx is your throat. Laryngopharynx is further on down. This allows passage of food, fluid, stratified squamous epithelium. Skeletal muscles, you have inner longitudinal and outer pharyngeal layer. The esophagus is a flat muscular tube from the laryngopharynx to the stomach. Pierces the diaphragm at the esophageal hiatus. If you've heard about hiatal hernia, it's because you've got too large of an area where it goes to the diaphragm and allows acid to go up back into the esophagus, which can lead to ulceration of the esophagus as well as esophageal cancer. The esophagus joins the stomach at the cardiac orifice. This is just showing the general makeup: mucosa, submucosa, muscularis, and adventitia. Okay, digestive processes. Ingestion, we start off with mechanical digestion. Mastication is chewing, partly voluntary, partly reflexive. You don't have to, you start thinking about chewing, but then you don't have to keep thinking about it. Chemical digestion, salivary amylase and lingual lipase start breaking down sugars and lipids. Propulsion, deglutition is the word for swallowing. Now, deglutition involves the tongue, soft palate, pharynx, esophagus. It's 22 muscle groups. The buccal phase is voluntary and involves contraction of the tongue. The pharyngoesophageal phase is involuntary. Control center in the medulla and lower pons. So we have here, you can see the bolus of food, right? Bolus of food is the yellow thing here. And then it starts, as you push it back, it starts to go down. The larynx is closed off, and we're pushing it down the esophagus, and it continues to go down until it finally goes into the stomach. Okay, layers of the stomach, and this is dissected out. This is a fundus here. This area is the cardia. The inside is always called the lumen of any organ. These are rugae of mucosa. Rugae are little folds, and that allows it to stretch. Lesser curvature, greater curvature. This is a pyloric antrum, the pyloric canal. This is a pyloric sphincter. And we have 3 layers. At most places of gut only have 2, longitudinal, circular, and oblique layer. And this stomach dumps out into the duodenum. Okay, the lesser omentum is a structure that goes from the liver to the lesser curvature of the structure, lesser curvature of the stomach, whereas the greater omentum goes from the greater curvature and goes anterior over the small intestines. And this is a picture of very dead, sort of rotten greater omentum, but freshly, it looks like, if it's a fresh tissue, it looks like lace and fat. Now, this greater omentum, if you get a little piece of damage, say like your appendix is leaking, it can actually move over and plug this area up. And so it can have a great use. Here's a picture of where your lesser omentum is. Okay, in the stomach, you have your submucosa, your muscularis externa, and serosa. So your layers, and the 3 layers, you have 3 layers of muscle. And you have a myenteric plexus in the stomach like you do everywhere else. Now the surface, you see all this surface epithelium, these gastric pits. Okay, simple columnar epithelium composed of mucus cells. Now mucus traps bicarbonate-rich fluid under it. And then you have gastric pits that lead to gastric glands. Now, guts, stomachs are made out of food, and so it's extremely important that they don't digest themselves. So this is why you have the mucus and the bicarb. Here are pictures of our gastric pits. They go down into the mucosa, and we have mucus cells, parietal cells, and chief cells. The neck cells secrete a thin acidic mucus. Parietal cells, we'll look at these other cells as we go through them. Okay, the parietal cells secrete hydrochloric acid. They denature protein and also activate pepsin and kill most bacteria, and also secrete intrinsic factor, which is essential for absorption of vitamin B12. Okay, chief cells secrete inactive enzyme called pepsinogen, which is activated by the hydrochloric acid from the parietal cells, and you get a positive feedback. And this continues to help digest protein. We also have enteroendocrine glands that secrete local hormones and local messengers that help control the movement of the stomach. Mucosal barrier, bicarbonate-rich mucus, tight junctions between epithelial cells, and also the epithelial cells that are damaged quickly are replaced. Okay, gastritis is inflammation of the gut, anything that breaches a mucosal barrier. Now, peptic or gastric ulcers are erosion of the stomach wall. Now, most would probably say many are caused by Helicobacter pylori. Other things, NSAIDs, corticosteroids, other drugs, large quantities of alcoholic beverages, many things can cause gastritis and gastric ulcers. This is actually showing an ulcerated piece of stomach, and this is a photomicrograph, actually a scanning electron micrograph, I believe, of Helicobacter pylori. Now, this is one of the most awesome stories in science. When Helicobacter pylori was first described, it was first found to be the causative agent of ulcers in 1982. Two Australian scientists, Dr. Robin Warren and Dr. Barry Marshall, had the hypothesis that it was Helicobacter pylori was the cause of gastric ulcers, because they kept finding this same bacteria over and over when they would culture biopsies. Now, I think that Dr. Marshall must have lost the draw or the flip coin, whatever, but he took the contents of a petri dish, mixed it in a drink, and drank some of the Helicobacter pylori. He did develop gastritis. Now, symptoms disappeared after 2 weeks, but he ended up taking antibiotics to kill the remaining bacteria because his wife could not stand him, because he had severe halitosis because the bacteria gave it to him. Okay, and this was published in 1984 in the Australian Medical Journal. This is showing movement of the stomach. The pyloric valve is closed, and the food is moving this way and this way and this way and this way, and you get grinding motion. And then retropulsion, you get a little of food, it's chyme at this point, it's let into the duodenum, and that causes the food to be forced back up, and so you squish, squish, moves around. Now, as chyme enters the duodenum, different types, as the food moves through, then you end up getting gastric emptying. It can't move forward until what's in the duodenum moves forward. Carbohydrate-rich food moves quickly and therefore moves out of your stomach quickly. So if you fill up on rice, you're going to be hungry very quickly. Fatty chyme remains in the duodenum 6 hours or more. So if you eat a big steak and a baked potato with butter and sour cream, you're going to stay full a lot longer. Small intestine, most absorption, digestion and absorption take place in the small intestine. It's probably about 4 meters long from the pyloric sphincter to the ileocecal valve. Subdivisions, the duodenum, which is still retroperitoneal, so it goes back behind the peritoneal cavity. Jejunum, and it's attached by mesentery. Ileum, also attached by mesentery. And this is showing a general picture of gut in general. This is the inner lining here. Well, here's your vessels here, and this would be in your mesentery. You have the fold, the outer layer, and your hepatic portal veins, hepatic portal vessels taking blood out to the liver. On the inside, you can see your villi and then your microvilli, and that tremendously increases the amount of absorption area you have, the villi and the microvilli. Okay, there we go. Now, the next slide is showing, villi. These are finger-like extensions, about 1 millimeter high of the mucosa. That's for absorption, the increased absorptive surface. And they also have goblet cells squashed in between their cells that secrete mucus. Microvilli come off of the projections off of the villi, and they create a border. Here, that's a villus. And then on the surface, bling, 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 over here, you have microvilli. So you can greatly increase the absorptive area. In the submucosa, one thing you have is Peyer's patches. These are little areas of lymphatic tissue that protect against bacteria. And also duodenal glands that secrete alkaline mucus. Intestinal juice is secreted in response to distension or irritation of the mucosa. Slightly alkaline, so therefore it's going to start to neutralize the acid from the stomach. Isotonic with blood, and it's mostly water, not a lot of enzymes, a lot of mucus. Facilitates transport and absorption of nutrients, but not the digestion per se. Liver is the largest gland in the body, 4 lobes, right, left, caudate, and quadrate. That's a picture of the liver, and there's your little gallbladder there. It would be green if it weren't dead. Functions of the liver: production of bile, which is essential for fat digestion. Also, bile contains the byproducts of breakdown of the red blood cells. Okay, production of plasma proteins, production of cholesterol, conversion of excess glucose into glycogen for storage, regulation of blood vessels of amino acids, processing of hemoglobin for its iron, so it recycles the iron, conversion of poisonous ammonia to urea, which will then be excreted in the urine, clearing the blood of drugs and other substances involved in blood clotting. Now, jaundice is the yellow color. It's due to liver failure. It's because the liver is not making bile, and therefore it's not taking the bilirubin, which is a yellow pigment that's the breakdown product of hemoglobin. Hepatitis, inflammation of the liver, often caused by a virus. Cirrhosis is scarring of the liver. It's often due to alcohol abuse. Okay, bile is yellowish green, alkaline solution. It's bile salt, cholesterol derivative, and bilirubin, which is formed from heme, and cholesterol, neutral fat, phospholipids, and electrolytes. The gallbladder stores and concentrates bile. So then when you eat, it releases bile into the cystic duct, which then flows into the bile duct. So here's your gallbladder, and then we have our common hepatic duct, bile duct. Now, something that I think is important, I never really understood when I was in school, and I think this picture has done me more good to understand it. Pancreatitis, this is our pancreas here. It's a life-threatening illness because the pancreas starts to digest itself, and your patient will die if it's not treated, and sometimes they will if it is treated. But one of the things that one needs to do is check that patient for gallstones. Now, if you look at this, if you had a little gallstone right here, I need to probably get a different color. There's black. Gallstone here, it goes here, comes here, and gets stuck right there. This is right along the same place that this pancreatic duct is. So when the pancreas tries to send digestive enzymes out into the duodenum, it actually is backed up. And pancreas is made out of food, and digestive enzymes digest food, so it essentially digests itself. A very life-threatening thing. Okay, the pancreas has endocrine function, which secretes insulin and glucagon to regulate your blood glucose. But the exocrine function is your digestive enzymes that are released. And if you don't have the pancreatic function, you do not digest your food. Peristalsis is the movement of food. Circular segments move food down along through the stomach. Okay, so peristalsis, wave of muscular movement that causes food to move along. Now, borborygmus is a gut sound. Borborygmi is plural for borborygmus. So listen to the gut sounds. Borborygma, borborygma, borborygma. Sounds just like its name. Okay, large intestines. We have our ascending, transverse, descending colon, sigmoid colon, rectum, and anus. We have our vermiform appendix and a little pitiful, nothing much of a cecum here. And the appendix was thought to have no use, just to be a vestigial remainder of when we had a functional cecum at some point in history where we digested leaves and grass and hay. But it actually probably does have something to do with your immune system. So it creates memory cells for your immune system and, helps you tremendously. So supposedly helps your doctor when he takes it out anyway. Now, the rectum has 3 rectal valves that stop feces being passed when one passes gas, assuming everything goes according to plan. The anal canal is the last segment of the large intestines, and it has 2 sphincters. Internal anal sphincter, which is involuntary, smooth muscle. External anal sphincter, which is skeletal muscle, therefore voluntary, and assuming everything goes according to plan. So here's your rectal valve, lets you pass gas. Okay, now here's your anal columns. These are hemorrhoidal veins. See the little blue things? They're not hemorrhoids, they're hemorrhoidal veins. A hemorrhoid is an enlarged vein. It may be in the anus, it may stick out of the anus, it may be minor, it may be major and require major surgery. Okay, bacteria flora is the bacteria and other organisms that live in the gut. Used to not be considered a big deal, but now we realize it's extremely important to have a healthy bacterial flora. Colonizes the colon, keeps the bad guys out, ferments indigestible carbohydrates, and they release gases and acids, which is not really something we like, but it does happen. Synthesize B complex vitamins and vitamin K. That's the reason we don't have to take vitamin K. Now, functions of the large intestine: water, vitamins, electrolytes are reclaimed. Propulsion of feces towards the anus. You can live without a colon, but it's nice that you have one because it absorbs so much of the water. Defecation is the process of going doo-doo. It's under parasympathetic stimulation, contraction of the sigmoid colon, relaxation of the internal sphincter, and then consciously we relax our external anal sphincter. Vitamin absorption in the large intestine, vitamin K and B vitamins that bacteria made are absorbed. Water absorption takes place, and also, okay, anything malnutrition in general can be more than one cause of malnutrition, but anything that interferes with digestion or uh, absorption, delivery of bile, not having delivery of bile, not having pancreatic juice. Without your pancreatic juice, you're not digesting food. Damaged intestinal mucosa, like maybe you have an infection or a virus. Gluten-sensitive enteropathy, celiac disease. This is an autoimmune disease that causes you to react to grains except rice and corn, wheat basically. You either have it or you don't. There's a blood test for it. Now, developmental aspects during old age, GI activity declines, absorption is less efficient, and peristalsis is slow. Diverticulosis, if this is a normal wall of a gut, a diverticulum has pouches that pooch out, so this will be the rest of the gut, and you can get little infections in these areas. Fecal incontinence, cancer of the GI tract, or other homeostatic imbalances. Cancer of the stomach and colon rarely have signs or symptoms. The metastasized colon cancers cause liver cancer. Prevention, regular dental hygiene and medical exams. The CDC guidelines for colonoscopy. Regular screening beginning at age 50. And if they find a little polyp like that, it can be taken out. Also, they do a fecal occult blood testing. Colonoscopy starts at age 50, and you do it every 10 years until age 75. Apparently, they don't take math to figure that statistic out. Anyway, so you do it 2.5 colonoscopies between age 50 and 75. Okay, that's all for this one, and that will be it.